Hello, everybody. For the next 10 questions, we're going to do something very different. I actually went through and recorded this for 30 minutes, but I realized that the record button was not on. So I'm going to blitz through the next 10 and explain the most high yield breakdown for each one. Our first question, we have a 60-year-old woman presenting to the clinic with progressive fatigue and weight loss. She's smoking a lot, 136/85, decreased breath sounds, and dullness to percussion of the right upper chest. She's got those engorged veins and the swelling above the clavicles. That tells us that it's a superior vena cava thing. And indeed, the answer is E. So this is SVC Syndrome. Swelling, hoarseness, and dilated neck veins would be seen here. And there's a mass effect. It's not the right lung apex. That'd be the pancostemur. It's not the right main stem bronchus. That'd be the atelectasis. And the left would not be on the right side, so it's not C. And the pulmonary trunk would cause pulmonary hypertension. All right, so those are the notes that I took on it the first time I did it, but now we're going to move on. Oh, last thing, chronic smoking, the mass grows in the SMA, or rather the mass grows and then it compresses the SVC, leads to JVD. And JVD is a distinguishing factor there. All right, these are the notes that I took on this next question. Here we have a guy, he's got recurrent episodes of quadrant pain, right upper quadrant pain after meals. He denies any nausea. He's doing okay. He takes metformin and a statin, and he doesn't have any rebound tenderness. What medication are you going to give him? He's just got gallstones. That's what this dude is suffering from. And so we're just going to give him some medication that just helps him out a little bit because he doesn't want to do a cholecystectomy. You don't want to do this because it'll increase the bile acid. You don't want to give him medication that inhibits gastric acid secretion. That's like a PPI or a Prazole. He has uncomplicated symptomatic cholelithiasis. And so the next best step is ursodeoxycholic acid, and it reduces the cholesterol content. So it just makes them into little weak stones. Super non-invasive. So it doesn't require any surgery, so that's why it's good for this guy. Yes, this A would worsen it. B, bile acid sequestrant. That would also worsen it by increasing cholesterol synthesis. PPIs don't have any role here, and increasing the pancreatic enzyme secretion is used for like cystic fibrosis or chronic pancreatitis. So these are the notes that I took on it, and now we'll move on to the next one. So here we got a dude, and he's got the world's most normal physical exam findings ever, and they're just asking you, hey, what's the area of cardiac conduction system that is responsible for the longest delay in the electrical propagation in this patient? And the answer is the atrioventricular node. Okay, so the AV is going to be the slowest, and there's that big pause before it goes into the left ventricle and does this big pumpy thing, because you have to squeeze every last drop of blood from the atrium into the left ventricle, and the AV has the slowest conduction and the longest delay before you go through the heart. All right, it's not the left anterior fascicle. That's not the delay, not the Purkinje. Those guys are super fast. The SA initiates the impulse, and the left bundle branch conducts very quickly. So the AV is going to be the slower one. And you got to know there's like a big pause there. All right, so for this one, I did a deep dive on the last video, which did not get saved. But we have a 14-year-old male, and he has some difficulty walking, and he's got like some neurological problems. And it's interesting because all they give us is like his cholesterol, and they're like, hey, what's deficient? And so you have to know that it's APOB. And the reason is because he has an MTP defect that prevents him from making the ApoB 48s and the 100s. That means that you don't get the chylomicrons that you need. You get the low plasma lipid levels, and you get vitamin E deficiencies. Because ApoB is super important for you to do those fat-soluble vitamin absorptions. And if you don't have it, then you have retinitis pigmentosa, which is vitamin A, and also you get the vitamin E problems. And so these A ones, like A1 and A2, those are going to relate to HDL. And A1 activates the LCAP metabolism with a high HDL metabolism. The ApoC activates lipoprotein lipase, so kind of different, and it would not cause hypocholesterolemia. And ApoE would not lead to malabsorption. All right, so here are the notes that I took on this, but basically you can't make the chylos or the VLDLs or the LDLs if you have an ApoB deficiency, because that 48 and also that 100 defect. And so he's got a beta lipoproteinemia. And that's why he has the ataxia. The reason he has the ataxia is because of that vitamin E deficiency. Again, I'm blitzing through all these because I already did all these questions beforehand. So here a 14-year-old male is presenting because he's complaining about walking and falling over. He's been struggling academically. He's got a wide-based gait. Oh, this is the same question. It's just ApoB. That's the retinitis pigmentosa stuff is the vitamin A deficiency. Okay, this one is super duper simple. It's just incidence versus prevalence. And so you just have to know that incidence is going to be 20 new cases of obesity per 1,000 patients that occurred during the 1-year time period. The only thing that's hard about this one is realizing that if they give you 5 years time, then you have to divide by 5. And that's pretty much all there is to it. Okay, so new cases, incidence numerator, total population over the past year, and then the qualifying factors. New cases, incidence. All right, super easy. Now this one is very important because the biggest things that you have to note here are the fever and the white blood cells and the flank pain. All of those things should tell you that this is pylonephritis, and that is ascending. That's an ascending problem, ascension of the bacterial infection. So the answer is C, because this is pyelonephritis, because the white blood cell casts are there, and there's fever and flank pain. The translocation of the enteric bacteria has nothing to do with this. That's bacteria in the intestinal mucosa. Immune complex stuff would be post-streptococcal glomerulonephritis, not pyelonephritis, and that's hematuria, so that's not seen here. And the bloodborne spread of the infection, a rare cause of pyelonephritis. And the fetal compression of the vasculature would cause hydronephrosis. Next question, we have a woman who has ALS and she has some like upper motor neuron signs, and they're going to ask, hey, what are you going to give her? You're going to give her a GABA B receptor. That's just going to be the first line therapy for ALS. And MDA is targeted by riluzole, slows the ALS progression by inhibiting glutamate. Alpha-2 adrenergic receptor is the target of tizanidine. The dopamine D2 receptor is targeted in movement disorders like Parkinson's, and the serotonin stuff, that's like ondansetron, so that's the antiemetics. Okay, the next question, a 32-year-old woman at 34 weeks gestation comes to the clinic, routine checkup. She's got no issues with her pregnancy except for the little baby does a little ultrasound and you see there's a fluid-filled sac even though the testes have descended. Okay, so we know that this is not cryptorchidism because the testes have actually gone into the scrotum, but they have not closed. And so that's the patent ductus, it's the patent processus vaginalis. And so it's the deficient obliteration of the processus vaginalis is what's caused that opening there. Here's a really good picture so you can kind of see this descends and embryology, the peritoneum kind of descends and it goes from the abdomen down into this scrotal space. And if that does not close, then you get that fluid there, but it's benign and it'll usually go away with time. This is crazy to say testicular torsion because that would be like, blockage of blood flow, much more acute and severe. And these other ones just don't talk about the issue, the failure of the urachus to close. That'd be like if you're peeing out your umbilicus. And so that's why the answer is B for this one. All right, this next one's pretty easy as well. It's a 67-year-old man who's got a history of hypertension and diabetes, a routine checkup, no problemos. And by the way, these are the notes on the last ones. And here is our guy. He's got some light brown pigments. They're just asking, hey, what is this? It's not hemochromatosis because that stains blue with the Prussian blue. And so this is indeed going to be lipofuscin. And basically what happens is as your cells age, they kind of start to break down. And you can see in the hepatocytes, the cardiomyocytes, and the elderly, and it's not harmful and it just does not stain like iron. Melanin would be the black and brown stuff. Calcium is chalky white, so not a Kavere there, nothing to see there. Amyloid would be the pale apple green bifringent Congo red stuff when it's displayed in a polarized light. So it's not the brown stuff. The brown is just benign. You're getting older, you're getting damage. All right, this next question is just a 50-year-old man presented to the clinic because he's got some unexplained weight gain, and they also tell you that he has Hürthle cells. Yeah, here it is. And so that just tells you immediately that it's Hashimoto's. Very nice of them to give you that. Just very textbook Hashimoto's. Essentially, he's got cold intolerance. Subacute is going to be painful. Follicular would not have the Hürthle cells and no lymphocytes. And anaplastic thyroid carcinoma is aggressive in elderly patients, and acute bacterial thyroiditis would cause fever and pain. And that brings us back to the present, where I noticed that this recording was not working. And as you can see, the bottom line here is that elevated TSH and low free T4 and lymphocytic infiltrate confirm chronic autoimmune Hashimoto thyroiditis. All right, folks, we did it. That was 30 minutes of recording that I've just consolidated down into just like 5 minutes or so. It takes a lot of time to make these questions and find the resources and find the best ways to explain them to you. So if you are benefiting from this, then please be sure to like and subscribe so we can grow this channel. And I'm going to make a quick song as well so you can listen to. And we'll see you guys in the next video.
Right up below, mass, yo, it ain't no joke. Smoker with hoarseness, that airways broke. Try tears shifting, percussion's dull. Post-obstructive pneumo lungs ain't full. Risk tobacco, redon, fam, 2 right bronchus block. Now what you gonna do? Right up below, with suspect cancer. Hoarseness, recurrent laryngeal nerve. Dough, percussion, and frommotes consolidation. Post-fat meal, pain in the rook, stones chilling in the gall without chola duck flu. No cut, cool, dissolve that rock, give her sodio, let the bile unlock. No surgery or sodadoxycholic acid, mechanism cholesterol and bile. Stones but no cholecystitis, watch and wait. ECG clean, but what's taking time? PRR's still 60, that's rhythm in line. AV no slowing, so the atria can squeeze, filling them ventricles with absolute ease. AV node longest delay allows ventricular preload. PR interval atrial to ventricle. Aphylexia pigmentosa in the eye, spiny RBCs got you wondering why. Low cholesterol, MCPs, the gene APOB gone, fat malabsorption seen. APOB absent, a deadly poppertiniac. Cracks it hard, do the math fast. 50 new cases in a 2,500 cast. Divide, multiply, incidence in sight, 20 per thousand. Epidemiology's tight. Incidence, new total Pylonephritis in years. Don't confuse with prevalence. Fevers, flank pain, 34 weeks in. Progesterone's chilling, ureters can't win. Urine's backing up, WBC cast roll. Multiply by 1,000 patient years. Don't confuse with prevalence. Fevers, flank pain, 34 weeks in. Progesterone's chilling, ureters can't win. Urine's backing up, WBC cast roll. Baclofen GABA B agonist used for Emerson Bay and spasticity. Hyperpolarizes motor neurons. Ultrasound drops. What's that fluid sac? Test is descended, but fluid got back. Patent PD that's processed, cyst left wide. Parental juice in the scrotal tide. Drosocilus patent processes vaginalis. Test is present, fluid's benign. Usually resolves on its own. Heart's looking small, brown in the shade. Iron stains neck, but age never fades. Lipofuscin's the pigment, wear and tear grind. Found in old folks, perina clear fine. Lipofuscin engine pigment, not iron. Found in heart, liver, brain. Fatigue, dry skin, cold all day. Got her with limps and hurtless slay. Anti-TPO got the gland in flames. Hashimoto's taking thyroid out the game. Gallstones and processes vaginalis. Test is present, fluid benign. Usually resolves on its own. Heart's looking small, brown in the shade. Iron stains neck, but age never fades. Lipofuscin's the pigment, wear and tear grind. Found in old folks, perina clear fine.